Welcome back to the deep dive, the place where we take those really dense sources like the core texts guiding advanced practice, and we synthesize the critical knowledge you need. Today we're tackling respiratory infections. It's a massive area, really fundamental to daily primary care.
Oh, absolutely. It's a constant challenge. For advanced practitioners, our mission isn't just treating symptoms, right? It's mastering the pharmacotherapeutic principles, knowing how to differentiate viral from bacterial causes, and, crucially, applying really strong antimicrobial stewardship.
Mhm.
Our sources actually highlight this huge economic burden estimates suggest, like non-influenza viral infections alone cost the U.S. economy around $40 billion annually,
Yeah.
just from lost work and caregiving.
40 billion. Wow. That's a staggering cost just for things like the common cold. That number alone really underscores why nailing that initial diagnostic step is so vital. Okay, so let's unpack this. Starting with the simplest one, maybe. The common cold. We know it's mainly caused by human rhinovirus, HRV, right? And since there's no actual cure, management is purely supportive.
Exactly. And to treat effectively, you really have to remember the underlying pathology.
Yeah.
When we talk about that runny nose, the congestion during a cold, we're not talking about a mad cell thing like allergies.
That's a really important distinction, isn't it? Because our first thought might be antihistamines, but that's not the main player here. So what is driving that classic runny nose and stuffiness?
It's the kinins,
Mhm.
specifically bradykinin. That's what causes the increased vascular permeability. And then the systemic symptoms, the headache, the low-grade fever, muscle aches, those are driven more by prostaglandins, which gives us our first angle for pharmacologic attack, managing pain and inflammation.
Right. Speaking of attack, let's start with the agents used to clear up congestion, the decongestants, like pseudoephedrine, oxymetazoline. What are they actually doing?
At the receptor level.
Okay, so there's sympathomimetic agents. They stimulate alpha and beta adrenergic receptors, mostly in the respiratory mucosa. This causes vasoconstriction, shrinks the blood vessels, and that helps improve ventilation and drainage, makes it easier to breathe. We see them available both topically, nasal sprays, and orally. Why is it important for practitioners to know the difference in terms of speed, side effects?
Speed is probably the biggest difference patients notice. Topical agents like sprays give you really rapid onset, sometimes within minutes. Patients tend to like that. Oral agents take a bit longer, maybe 30 minutes or so. But, and this is a big but, using those topical agents carries a serious risk we absolutely have to counsel patients about: rhinitis medicamentosa.
Ah, the rebound congestion,
Right.
where the swelling comes back even worse than before.
Exactly. That can happen if they're used for more than 3 days. Basically, the receptors become less sensitive. Plus, with the oral agents, you get systemic absorption, which brings in major safety concerns. What would you say is the absolute biggest risk you need to check for before recommending something like pseudoephedrine?
It's got to be the cardiovascular risks, surely. We're stimulating adrenergic receptors, so you worry about bumping up blood pressure, heart rate.
You got it. Severe uncontrolled hypertension and coronary artery disease are major contraindications. You also need to screen for narrow-angle glaucoma. And here's a critical one that can cause a hypertensive crisis: using MAO inhibitors concurrently or even within the last 14 days. These aren't minor warnings. These are serious patient safety flags. We really need to watch for them.
Okay, let's pivot slightly to cough. We generally have two main categories: expectorants like guaifenesin and antitussives like dextromethorphan. My takeaway from the sources was that the evidence for either of these in the common cold is, well, let's just say it's underwhelming.
Yeah, that's a polite way to put it. For expectorants, honestly, the benefit of guaifenesin over just telling someone to drink more fluids is marginal at best, and it takes an hour or two to even kick in. For antitussives like dextromethorphan or benzonatate, the benefit for just a standard cold cough is minimal, and we generally avoid narcotic antitussives altogether now.
I did notice a specific warning against something patients do all the time: grabbing those combination products that mix both expectorants and antitussives. Why is that considered bad practice?
Well, it's kind of counterintuitive, isn't it? They work against each other. An expectorant is trying to help you cough up secretions, thin them out, while an antitussive is trying to suppress the cough reflex. So you're essentially giving two drugs with opposing mechanisms. It's often ineffective, and it's just over-medicating.
Makes sense. Now let's circle back quickly to pain and inflammation, the NSAIDs. For those prostaglandin-driven headaches, muscle aches, there was a detail here I found really interesting about viral shedding.
Yes, this is a major clinical pearl, actually. Some guidelines suggest naproxen as the preferred NSAID.
Hmm.
Why? Because evidence shows it doesn't seem to impact viral shedding, which is different from ibuprofen or acetaminophen, where there's some thought they might actually prolong how long someone sheds the virus.
So wait, just by recommending one NSAID over another for simple symptom relief, we might actually be influencing community transmission rates. That kind of changes the calculation, doesn't it?
It really does. It links our very specific pharmacologic choice right back to public health implications. But, whichever NSAID you consider, always remember the crucial pediatric warning. No aspirin in children. Ever. Because of the risk of Reyes syndrome.
Got it. Okay, to wrap up managing the common cold, we looked briefly at anticholinergics and antihistamines. The sources mentioned apratropium bromide nasal spray specifically for rhinorrhea.
Yeah, that one works by inhibiting secretions, so it's pretty good for just the drippy nose aspect. But it's not consistently effective for congestion or sneezing. And as for antihistamines, generally they're ineffective on their own for cold symptoms. They can even make congestion worse sometimes because they dry things out too much. We might consider the first-generation ones, like diphenhydramine, but really only in combination with the decongestant and only if there's significant rhinorrhea or that feeling of fullness in the ears.
And a quick safety reminder on those first-gen agents.
Yeah, be cautious, especially in older patients. They cross the blood-brain barrier much more easily. That increases the risk of confusion, dizziness, falls, all due to their anticholinergic effects.
Okay, so we've navigated supportive care for the common cold. Now let's wade into what feels like the biggest antimicrobial battlefield in primary care. Rhinosinusitis. Our sources point out that, up to 98% of these cases get antibiotics inappropriately, even though most are viral. AVRS.
This is absolutely where we earn our stripes as advanced practitioners. It's imperative, really, that we use the IDSA criteria to avoid just handing out antibiotics for acute viral rhinosinusitis. We're looking for 3 specific sort of hard-stop clinical scenarios to even justify diagnosing acute bacterial rhinosinusitis, ABRS.
Okay, walk us through those 3 criteria again, because this is the core decision point, right?
Right. First is persistence. Symptoms that just hang around for longer than 10 days without any sign of improvement. Second is severity. Really severe symptoms. Think fever over 102 degrees air plus facial pain, or purulent discharge lasting for 3 to 4 consecutive days right from the get-go. And third is the double sickening. That's where a patient starts to feel a bit better, but then bam, their symptoms dramatically worsen again.
Okay. So if we do meet one of those criteria and we decide we really need to treat ABRS, the first-line drug is usually amoxicillin-clavulanate, Augmentin. Why do we need that clavulanate piece?
Good question. Amoxicillin itself is a beta-lactam, works by inhibiting bacterial cell wall synthesis. We add clavulanate because it's a beta-lactamase inhibitor. Think of it like body armor for the amoxicillin. It stops common respiratory bacteria from using their enzymes to just chew up and deactivate the drug.
And when do we need to step up to the high-dose regimen, that 2,000 milligrams twice a day?
We save that high-dose approach for patients who either have a really severe infection or who have specific risk factors for resistant strep pneumo. That includes the very young, so under 2 years old, or older adults over 65. Also the immunocompromised, kids in daycare, or anyone who's had antibiotics recently. Those situations mean we need to hit the potential bacteria harder and faster. And just remember, the most common side effect you'll hear about is diarrhea.
Right. Now, for adult patients who have a penicillin allergy, the usual next steps are doxycycline or maybe a fluoroquinolone. Let's touch on doxycycline first.
Okay, doxycycline. It's a tetracycline technically used off-label for ABRS. Its mechanism is binding to the 30S ribosomal subunit, which stops bacterial protein synthesis, so bacteriostatic. Now, a really crucial counseling point here, chelation. Patients absolutely must avoid dairy products, antacids, iron supplements for about 2 to 6 hours around the time they take doxy. If they don't, absorption plummets. Also, remember the age restriction. Generally not recommended for kids 8 and under.
Okay. And then we have the fluoroquinolones, like levofloxacin and moxifloxacin. Highly effective, yes, but they come with some really significant warnings.
They absolutely do. Their mechanism is potent. They inhibit essential bacterial DNA enzymes, causing the DNA strands to break, but they come at a potential cost. They carry that infamous black box warning for tendinitis and tendon rupture. And this risk is even higher in patients over 60 or anyone taking corticosteroids at the same time.
Tendon rupture, that sounds pretty extreme. Can you give us a quick rundown of the other major warnings?
Sure. We also have to remember they're associated with QTC prolongation that can mess with the heart's electrical rhythm. And there's an increased risk of aortic aneurysm ruptures. So yeah, these are definitely not first-line agents unless we really have to use them due to allergies or treatment failure.
And just quickly for our pediatric providers listening, for kids with a penicillin allergy needing ABRS treatment, The alternative is often combination therapy, right? Like clindamycin plus a third-gen cephalosporin.
That's correct. Typically clindamycin plus something like cefpodoxime or Cefixi.
Okay, moving down the respiratory tract now. Let's talk lower respiratory infections. Acute bronchitis first.
Right. Acute bronchitis is almost always viral. Diagnosis is usually about exclusion, making sure it's not pneumonia, often with a chest x-ray if needed. And the key takeaway, antimicrobials are generally not recommended.
The main exception being if you suspect influenza, correct. That's when we might use the antiviral oseltamivir, Tamiflu.
Exactly. Oseltamivir works by inhibiting neuraminidase. That's an enzyme the virus needs to get released from the infected host cell and spread. The absolute key pearl here is timing. It's most effective by far if you start it within 48 hours of symptoms starting. We also need to be aware, particularly in kids, there's a slightly higher risk for side effects like confusion or delirium.
Good to know. Okay, finally, let's tackle community-acquired pneumonia, or CAP. This needs clinical symptoms correlated with objective data, usually that consolidation on a chest x-ray. How do we quickly break down the approach to empiric outpatient treatment?
It really comes down to risk stratification. We basically separate patients into two main groups. If the patient is otherwise healthy, no significant comorbidities, no major risk factors, we can usually start with high-dose amoxicillin or doxycycline or a macrolide like azithromycin or clarithromycin.
Okay. And what if they do have comorbidities? Things like chronic heart, liver, or lung disease, diabetes, alcoholism, malignancy?
That changes the game. We need broader coverage then. So that usually means combination therapy, either amoxicillin-clavulanate or a cephalosporin plus a macrolide or doxycycline. The or option is respiratory fluoroquinolone monotherapy, like Levo or Moxi. This combo strategy helps ensure we're covering not just typical strep pneumo, but also atypical pathogens.
Let's quickly recap the pharmacology of those macrolides, azithromycin, clarithromycin. We need to remember more than just that they bind the 50S ribosomal subunit, right?
Oh, absolutely. While they inhibit protein synthesis, the two big practical warnings are QTC prolongation, again, that heart rhythm issue, and significant CYP3A4 inhibition.
And remind us why CYP3A4 inhibition is such a big deal clinically.
Right. CYP3A4 is a major liver enzyme responsible for metabolizing lots of other drugs. When macrolides inhibit it, they slow down the body's ability to clear those other drugs. So if your patient is on, say, warfarin or cyclosporine or certain statins, their levels could shoot up dangerously high. That's a really critical drug interaction to watch for.
Got it. And what's the typical duration for CAP treatment? How long should they be on antibiotics?
We look for clinical stability, meaning the patient is clearly improving, usually within 48 to 72 hours. Antibiotics must be continued for a minimum of 5 days, and basically until the patient is demonstrably clinically stable. So to kind of wrap up the essential clinical pearls we covered, for most viral infections, remember the goal is purely symptom management. Don't reach for antibiotics. For bacterial infections like ABRS or CAP, successful antibiotic selection isn't just about the bug. It really depends heavily on the host's risk factors, their age, where they live or work, recent antibiotic use. All that stuff informs the risk of resistance.
So what's the bottom line for daily practice? I think the driving force across all these principles, from, avoiding those cold combo products to picking the right CIP regimen, it all comes down to appropriate antimicrobial stewardship. And patient education is just fundamental here. They need to understand why antibiotics won't help their viral URI. And if they do get prescribed antibiotics, why it's so important to finish the full course even if they start feeling better early on.
It's a constant effort, definitely. And these clinical decisions really do have high stakes.
And finally, let's revisit that really fascinating detail about viral shedding. We noted some guidelines favor NSAIDs like naproxen because they don't seem to impact shedding, unlike ibuprofen and acetaminophen, which might prolong it. So given how much focus there is now on virus transmission in the community, how should practitioners weigh that immediate therapeutic benefit of a common fever reducer against the potential, maybe small but real, impact on viral shedding for the whole population? That's maybe a thought for you to mull over, something to consider in your next patient conversation, perhaps. Thank you so much for joining us for this deep dive. We really appreciate you being part of our little last-minute lecture family. We'll catch you next time.